All right, so we're recording now. So this is video number 5 in the 6-part video series on ARDS and prone positioning. My name is Lexi Graham, and in this video, we're going to be talking about the rationale for prone positioning. Why do we prone? Proning patients is a medical procedure that helps patients with acute respiratory distress syndrome, ARDS, to breathe better. It is often performed in ICUs when a patient is not responding well to a ventilator. It improves oxygenation. Proning reduces the compression of the lungs by the heart and abdominal organs, which improves gas exchange and oxygenation. It redistributes blood flow and airflow. Proning helps to balance blood and airflow in the lungs, which improves gas exchange. And then it helps drain fluid from the lungs because gravity is doing all the work, which improves the clearance and reduces wet lung tissue. Proning patients takes away off the lungs, which allows more air to get into the alveoli, thus improving oxygenation, ventilation, and gas exchange overall. When is proning indicated? So providers use proning to get more oxygen to people with severe respiratory conditions who aren't getting enough, but it is most commonly used for ARDS patients. When an ARDS patient has refractory hypoxemia, which means you're giving them oxygen and it's not improving, and then oxygen saturations that are between 60 and 80. And then the patient needs rapid oxygenation to get their sats up. Those are the patients that we are proning. The reason proning works is largely because our bodies aren't asymmetrical. So proning does 2 things to get more oxygen into your body. It decreases the amount of weight and compression on your lungs, allowing more air to get into your alveoli, improving ventilation, and then improves your lung efficiency by getting oxygen to the parts of your lungs that get the most blood flow, which would be the improved gas exchange. When prone positioning, there are some contraindications, so reasons why we would not prone someone. If they have severe arrhythmias, pelvic fracture, increased ICP, spine instability, recent sternotomy or cardiac surgery or peritenostomy. And then some more relative contraindications include a tracheostomy within the first 24 hours of having it, bronchopleural fistula, alveolar hemorrhage, ophthalmologic surgery, intraocular pressure, pregnancy, or facial trauma. So these patients, we are not going to prone them because they will not tolerate it well, and it's not good for them sometimes. Pre-term considerations. So before you prone someone, you're going to consider these aspects. Confirm that the patient has none of those contraindications we just talked about. We're going to secure drains, catheters, and other lines that could be dislodged from the patient. We're going to reposition their ECG onto their back after they're flipped. That way they still get those readings. We're going to stop all tube feeds. We're going to ensure adequate padding for all pressure points like the face, knees, chest, abdomen, and ankles to make sure those don't get pressure sores. We're going to secure the ET tube with proper placement and stabilization. Consider pre-oxygenation as well as suctioning the patient before we turn them. The RT always is the one doing the counts. So when you're doing 1, 2, 3 flip, we are the ones that say that because the airway is the most important part. And then make sure you have the appropriate amount of personnel to help complete the procedure because you do not want to be doing this by yourself. So a prone position therapy checklist. These are things we're going to do while we are proning. So for number 1, pre-prone check. We're going to gather our supplies and personnel, designate roles, and acquire the appropriate PPE if necessary. We're going to prepare. So we're going to prepare the lines and attachments to the patients, like I said before, making sure they're all in line and out of the way. And then 3, you're going to cocoon the patient and wrap them up kind of like a cocoon or burrito. Make sure they're secure when you're flipping them so they don't fall out of the sheet. And then for the movement, you're going to do the horizontal move. After you do horizontal, you're going to lay them on their side. And the final turn is to their stomach. And then lastly, you're going to put them in that swimmer's position and then check your post-turn checklist. We also have a thing called a rotoprone bed. So there are also techniques in using the bed. The steps would be to position the patient on the bed's rotoprone surface, center the patient's head in the head support, Align the patient's ears with the openings of the head support, and then secure the patient in the bed. Press supine or prone button on the screen or hand controls to rotate the bed. You're going to rotate the bed in continuous motion, and then monitor the patient's time lines and tubes as well during this. So effectiveness and assessment on how to know prone positioning is working. So since placing patients in the prone position can reduce mortality rates for ARDS, patients can be placed in prone positions for durations of 12 to 18 hours. So to know if it's being effective, healthcare professionals typically monitor the patient's oxygen saturation by pulse ox or the PaO2 by ABG. The patient's SpO2 should improve significantly when being placed prone, along with other signs like decreased respiratory rate and decreased work of breathing. You may also be able to assess the patient with a chest x-ray to see if there is improvement in the lungs compared to a previous x-ray, like we had seen in the other previous videos, talking about the aeration improvement. And then you also have skin breakdown prevention. So you want to do this with any prone patient. So you need to regularly reposition their ET tube like you normally would, assess skin breakdown by removing devices or tape daily, sometimes two if is ideal. Make sure the head is turned one side to avoid pressure on the face and ears, proper padding and support surfaces, meticulous skin care and frequent skin checks with proper moisturizing, monitoring those pinpoints, and then you're going to use pillows to support the head, neck, and limbs in a neutral position while they're prone. Protecting bony prominences like the forehead, cheekbones, chin, breastbones, hips, knees, and ankles. And also, you can educate providers on proper prone positioning techniques in order to assist helping with all these preventions. So, you also have limb positioning and passive movement considerations. So you're going to position the patient in a swimmer's position, like I had said before. The patient's face is facing the hand and arm that is raised to the 90-degree angle. So like this. Not how he's doing the photo. His face should be facing his arm. But the alternate arm should be positioned down along the side of the body with palm up to ensure that you have all personnel. And you should also ensure that you have all personnel in order to put the patient in this position, like I had said before. In the ICU, the rotation of the head with the face toward the abducted arm facilitates the access to intravenous lines, clear visual assessment, and manipulation of the airway, and avoids pressure on the face. This is why we do the swimmer's position. So, furthermore, the rotation of the head advised within the swimmer position would maintain an open neural foramen on the adducted side, theoretically relieving local pressure on the emerging nerve roots. So the whole reason that we do this is to relieve pressure in other areas and have clear visual on lines on the patient. And then I have a video demonstration that we can watch.